She has been working in nonprofits for about 20 years, and 14 of those have been at Methodist Healthcare Ministries. She is excited about results-based thinking and management, and our department here oversees about $30 million in grants made each year, and is responsible for the part of our team that's evaluating and communicating the impact of MHM's grant portfolio, which includes C-Texas, which is our SIF-funded project here. Before Anne got to MHM, she spent 8 years in a data mining and predictive modeling career. And just some fun facts about Anne. She loves her terriers, yoga, bicycling, and singing in her church choir. And her favorite virtues are courage and kindness, which I can attest to working on her team for the last 3 years. So I'm going to introduce Anne. She's going to tell us all about data sharing to advance a common agenda. Enjoy.
Thanks, Stephanie. Hi, everybody. So I think I will just kind of start with the why. Before we even get to why data sharing, why a common agenda, and just to get an idea of where you all stand, let's start with a quick instant poll, and if you could please indicate whether you are familiar with the collective impact framework. And you should see some poll questions, I believe, to the right of these slides.
Okay, so I've closed the poll, and I'm going to share those results in a moment once WebEx lets us show them.
Okay. Well, it looks like we have a pretty good grasp on collective impact. So what that tells me is I'm going to pretty much speed through the next section since you all should be familiar with collective impact. So we know that we are trying to get away from the old school isolated impact and where everybody's kind of working in isolation. And the reason that we do this is because solving these social problems is not just complicated, it's complex. And I love this graphic, the idea that sending a rocket to the moon is complicated, raising a child or anything else to do with health and human services is complex. So if we're going to embrace complexity, and you can hear the groundwork being laid for the data issues with complexity, we do look at the collective impact approach. And progress with collective impact depends on working toward the same goal and, of course, measuring the same things. And you all are familiar with the 5 conditions of collective impact from Kania and Kramer. And anybody who is not, feel free to chat in and let us know if you have any questions about that. Okay. So I'm going to move on to the data sharing piece. What does data sharing have to do with a common agenda? So data sharing is really about aligning purpose. It allows subgrantees to work together toward common goals. And I will say that it is critically important to get subgrantee buy-in when you're using shared measures. The next 2 slides I'm going to show are taken from our consensus building workshop, which is what we use to get that buy-in. So how we built the consensus. the advanced work of building an inventory in which we polled the subgrantees, created a spreadsheet, showed how much overlap there was among metrics, that made it possible to do this consensus building in a relatively short amount of time. I think if we had not done kind of an environmental scan of all the metrics that they were using, it would have taken a lot longer with the in-person piece. So the consensus building session was run by our external evaluator, Health Resources in Action, or HRIA, and that's their logo down there in the lower right. So they led this process for us, and then there was some follow-up after the consensus building session as well. So, interesting thing, the subgrantees were united in wanting to measure the chronic disease metrics and the mental health metrics. However, there was less consensus on the quality of life cluster. And MHM eventually made that decision top-down for them for pragmatic reasons. We agreed with our evaluator, HRIA, and with the CNCS evaluation team that having something more near-term or intermediate as a result would be good for demonstrating the value of the work before the full evaluation was complete. So we were looking at short, mid, near, long, you know, all of that in terms of time frame. So that was one piece. And I think also the quality of life captures some more of those intangibles, but isn't it nice that there's actually a validated scale for that? Okay. So the image you see now is the social network map. And the idea behind this is that not everybody has to be doing the same thing to drive toward the same goals. So the social network map indicates all the different connections, the different ways that our subgrantees are connected, and it does look complex. And I will underscore that it's really, really hard to drive toward the same goals when you're doing different things unless you're sharing data. Which brings us back to a collective impact concept, which is mutually reinforcing activities. So an example of what I mean, mutually reinforcing activities are different activities that drive toward the same outcomes. So all the activities you see on this slide might contribute to improved HbA1c control, reduced BMI, controlled blood pressure, and so forth. So to get to the role of data sharing and continuous communication, another one of the collective impact planks in their framework, this is a screenshot from some data sharing software designed for collective impact projects. And this screenshot emphasizes the importance of communicating results and the contribution of each partner agency to the cause. It's helpful for collective impact projects to have a public-facing option to help communicate with stakeholders and potential match funders. And also, of course, public-facing options to increase transparency. Then I'm going to veer off collective impact to something related, which is the systems approach. This has been getting a lot of national attention from GEO and others right now. And collective impact grant making with shared data for a shared agenda really does fit beautifully into the systems perspective. And just to highlight a couple of these points, these are taken right from GEO. Systems thinkers look at ecosystems, which are interconnected entities that cannot be reduced to discrete parts. So that has to do with moving toward this common agenda and being able to keep track of all of that. Systems thinkers also understand that every part of the system affects and is affected by other parts of the system. And systems grant makers look for patterns over time. they don't necessarily expect them to stabilize, but they're constantly tracking patterns. Any questions so far? Please feel free to chat in if you have questions. Okay, I'm not seeing anything, so I'll move to the next one. Okay, so a data implication of the systems approach and of using the collective impact framework is that you really need to be looking at interaction effects. And what you're seeing here is a hypothetical example of a decision tree, which is produced by shade analysis. If you're not familiar with that, I will, in my geekiness, share this with you. It is chi-squared automated interaction detection, and all that means is that it helps you see how a combination of factors affects outcomes and not just one factor at a time. So you can see how if everybody's doing something different, this becomes especially important in your analysis. You're not just looking at, we did this one thing, everybody did the same thing, and here were the results. You're looking at, in different combinations of these interventions and variables, where do we see the greatest lift, the greatest change. So this type of analysis clearly requires shared data. Okay. So Methodist Healthcare Ministries SIF project, C-Texas, has the first ever hybrid SEP structure. So we have a multi-SEP, which is sort of akin to the idea of the mutually reinforcing activities and collective impacts, with each subgrantee doing something different, and in some cases they're quite different. And then we also have an overarching SEP, which is where the shared measurement especially comes into play. So we're looking at change across the entire portfolio. That's not the same as a uni-SEP, because with the multi-SEP we have both the overarching and the multi-SEP. So that's all nice kind of SIF jargon. Please feel free to chat in if you have questions about that. Okay, not seeing any, so moving on. Okay, so there are long-term and short-term implications for building the capacity of your subgrantees, something that's very important with Social Innovation Fund grants, to any kind of data sharing solution. And there is a healthy tension between short-term evaluation goals and long-term needs for capacity building. And I'll just get that slide. So when you're looking at your evaluation, you need a way to track progress stat. That's something that's very immediate in the need. However, some of the data sharing solutions I'm going to talk about take considerably longer. So that kind of puts you in that, okay, so what do we do in the meantime position. So I'll move to the next instant poll. So we'd like to ask you if you have a way to pull subgrantee data for evaluation purposes. I'm assuming that most of you do, unless you're brand new to this. And then if so, what type of database are you using for the evaluation? And in case there are any screen wrap issues, the choices for that second part are purpose-built collective impact software, custom-built patient registries, health information exchange, constituent relationship management or CRM systems such as Salesforce, access-type databases with a central collection of flat files, or something else that I haven't thought of here. So you can go ahead and respond to that poll. Jessica, do I want to save the poll results? I don't know whether to click yes or no here.
Oh, don't worry about that. I'm going to close it right now.
Okay.
Yeah, sorry folks, there's a little bit of a delay with WebEx calculating the poll results. Okay, those should show up.
All right. Okay, so some mixed results on pooling subgrantee data. And then it looks like, all right, looks like the others have it. So if you selected other, if you would mind, please do type into the chat window and share with folks what is the other solution that you're using for evaluation. And I'm not seeing any responses from where I'm sitting. Okay. Jessica, are you seeing responses at your end on the chat?
No.
Okay.
No.
All right, well, we'll just move along then. So everybody's obviously collecting data for evaluation, but it looks like they may not actually be pooling the data. So that makes sense. Okay. So moving on to the next slide. Okay. So we have another instant poll. So moving on from the question about pulling data for the evaluation, I'd also like to know, are you considering or currently using a way to pool subgrantee data for long-term collaboration purposes, that being a little bit different than the more immediate need of evaluation? So long-term in this case means either during the scaling phase, after the evaluation, or after the end of the grant period. So if you're using a solution and it's different than what you're using for the evaluation, I'm curious to know what that is that you're using for the long term. So you can go ahead and respond to that poll.
And we've got a few folks who are still in progress, so we'll just give another few seconds to let them finish up.
Okay, so I see the results. There are a couple of you using the same solution for your short and long term. and then there's some not sure, no answers. Okay. So the patient registry is also helpful in this situation, as is the CRM system. Interesting. Okay, great. So I would imagine from the results that you all have also encountered this tension between the short-term and long-term approaches. Okay, so there are many options for databases, and as you just got a sneak preview of the types from taking that poll, I'm not going to read you the list. All of these have their pros and cons, and all can build subgrantee capacity to some degree. So I'm going to go through the list and just sort of do a little market scan in terms of what's out there. There's a whole new class of software that's sprung up just since collective impact became a thing. The two market leaders that I've seen in this category are called Results Scorecard and Insight Vision. I'm not going to get into depth on those because this is not meant to be a sales presentation by any means. So this screenshot shows some features of Results Scorecard, just to give you an idea of what it is. And you see where I put my blue arrow on the right. There's an emphasis on data sharing, not surprising with collective impact. And then to give equal time, these are screenshots showing some features of Insight Vision, which is another one of those in the collective impact category. Okay, so there are a number of pros and cons to this type of software. It is closely aligned with advancing a common agenda, which I like, and notably it has some really nice public-facing tools. I love the ability for live drill down. You can start at a very high level and drill all the way down to different subgrantee programs and even sites of those subgrantees. The cons, well, it's fairly expensive, and then also because it tends to track programs in real time, it may not be as appropriate to use those public-facing tools until after the SIF has approved sharing your evaluation data. So it makes the live real-time data sharing to the public less applicable. Does anybody have experience using this type of software, or their subgrantees have used this type of software where they would like to share? If so, please chat in. Okay. Doesn't look like we have anybody who's used this. So moving on to patient registries, I saw at least a couple of you are using these. These are known for tracking a specific patient population, usually associated with the chronic disease, and they're very helpful in being able to monitor performance of the practice team. And it's nice because I know you can get down to the provider level and see how are patient panels for different providers performing. And I'm not going to spend too much time on this because we have a guest speaker from the John A. Hartford Foundation who's going to talk a little bit more about their experience with it. But just to go through some pros and cons, the patient registries are flexible in terms of patient consent, so not as restricted as a health information exchange. This is something we learned when researching health information exchanges. So that makes the patient registry pretty attractive in terms of the informed consent process. Also, it can be very customizable to the evaluation. It does tend to have a more finite lifespan compared with, say, an HIE, and it is generally more limited to evaluation participants rather than, you know, every healthcare provider in the community, unless it's linked with an HIE, which actually is an option, although it's not normally part of a patient registry. So at this point, we'd like to hear from the John A. Hartford Foundation. And I imagine we will need to unmute somebody there.
Hi, Ann. This is Wally.
Oh, hi, Wally.
Can you all hear me? Okay, terrific. So I'm unmuted.
Oh, great.
Fantastic. Well, thank you so much. I'm really delighted to share our experience with patient registries and to give you a little bit about our story. And also delighted that I have joining with me today one of our SIF subgrantees, and I'll introduce her and the organization she works for in a minute. Let me just first reflect back on a couple of the comments that Ann presented on earlier. So the model that we are using to target depression in underserved rural areas in Alaska and the Pacific Northwest is a model called collaborative care. And interestingly, it draws on many of the same ideas and principles that are also relevant for collective impact. The difference is that you know, collaborative care is a way to address a solution and in effect to create impact within a clinical organization. And, you know, where we talk of cross-sector alignment and collective impact, in the case of a clinical setting, what we're talking about there is alignment across a host of different, well, a team of different providers. And we're also talking about, you know, ensuring that there's active coordination amongst those providers and that the providers are all working towards the same goal and measuring the same thing. So very much the same idea of collective impact, but just within the clinical organization. And in fact, if I could just spend a minute to describe what the overarching principles of collaborative care are, I think you'll see how this really connects quite beautifully with the slide that Ann presented earlier about embracing complexity, because the principles of collaborative care are a way to deal with complexity within a clinical setting. So very briefly, first and foremost, collaborative care is about putting the patient in the center of team care. And what that means is that ideally, when you have all clinical providers working together, they'll be on the same care plan for a patient. And so this is a way to ensure that everyone is all on the same page and understands, what is most important to the patient and how to help that patient achieve a particular health outcome. Secondly, it's about population-based care, as you heard from Ann earlier. This is one of the reasons why registries exist. It's to ensure that you can track a group of patients with a particular condition or set of conditions, and you can monitor how well that group or population is doing over time. And then a couple of other things that the patient registry also allows us to do, which is to support a couple of things which are crucial to collaborative care and really to, in the same spirit of SIF. So one, it's to ensure that patients are getting treatments that are backed by evidence-based studies. So there's credible research evidence to support the efficacy of these treatments, number one. Number two, it's about ensuring that every patient's treatment plan, clearly articulates the personal goals and clinical outcomes that are supported by these evidence-based care protocols. And what that means is that if to put it in a nutshell, if a patient isn't doing well, then the providers should come together to think about what else they can do to change a treatment or make adjustments in how they're caring for a patient so that the patient gets better. Of course, neither of those things are possible without hard data that describes exactly how the patient's doing. And fifth, and last but not least, it's the patient registry is also a way to reinforce accountability across the different providers. And again, you heard Anne mention this when she talked about how you can track outcomes by provider. So all five of those things that I described, as you can see, do echo the same themes that we find in collective impact, and not surprisingly, because it is about embracing complexity inside a clinical setting. So to give you a real setting, I'm very delighted to have with one of our partners, Andrea Wersching-Batasha, and let me just confirm that Andrea is on the line.
I am.
Okay,
hi, Wally.
Terrific. Good afternoon. And Andrea works for Partnership Health Center, a SIF subgrantee, which is based in Missoula, Montana, and it was received its federal designation as a federally qualified health center in 1992. It serves a medically underserved area as well as a dental health professional shortage area. The organization has grown tremendously over that time, and today it provides medical, dental, pharmacy, behavioral health, as well as other services to patients in Missoula and in the surrounding rural counties. In 2015, they served over 15,000 unique patients, approximately 20% of which were covered through Medicaid, 14% Medicare, 39% self-pay, and that basically means the folks who are uninsured, and about 27%, about a quarter, through private insurance. A couple words about Andrea. She's a really fun person to work with, and is the Behavioral Health Services Director. She's been the lead since on the impact work, as well as lead for the department since 2013, and she has a bachelor's degree in psychology from UT San Antonio, as well as an MA in mental health counseling from St. Mary's University, and she has over 12 years of experience in the mental health field, and her clinical specialties include clinical supervision, trauma-focused cognitive behavioral therapy, as well as problem-solving therapy. So with that, without further ado, let me pass it over to Andrea to talk about her experience with the implementation of our patient registry.
Thank you, Wally, for that very warm introduction, and it's always fun to work with you as well. I'll give just a brief snapshot of what our integrated behavioral health care looks like at Partnership. Our behavioral health team is comprised of a behavioral health care manager and a therapist. We do universal depression screening in the medical clinic, and so when a primary care provider identifies that a patient has depression, they'll call for a behavioral health care manager to come down and introduce services, do some psychoeducation, and set up an initial treatment plan based on patient input and provider input. And there the treatment plan can expand to follow-up phone calls with the care manager and/or therapy. And therapy consists of evidence-based practices, usually starting off with problem-solving therapy. But as treatment changes are required, we can look at other modalities. For care management, follow-up calls consist of continued psychoeducation, symptom monitoring using the PHQ-9, medication adherence, and creating behavioral activation goals to help reduce symptoms. But at the heart of all of this work is our patient registry, where we're specifically tracking patient treatment outcomes in regards to their depression. And this tool drives all of our clinical decision-making within the team, which is different from the way it looked before we did collaborative integrated behavioral health. Before the registry, it really was driven by the therapist, and they were required to hold all this information and make all these clinical judgments based on patients, and oftentimes just patients self-reporting improvement or not improving with their symptoms. With the registry, that really made it concrete for us. We were able to track symptoms based on the PHQ-9. The score for that measure can range anywhere from a 0, indicating no symptoms, up to 27, which is severe depression. The threshold is a 10. If people are scoring a 10 or higher, we're recommending that they participate in depression care services. And we do ongoing monitoring by administering that. And that's entered into the registry. So we have a lot of different team members working on that. The behavioral health care managers will enter in their follow-up calls and PHQ-9 scores, as well as the therapists will enter in their session notes and PHQ-9 scores when they collect those with the patients. And then as a treatment team, we're using the registry to evaluate if a treatment change is needed. And what we found is as a team using the registry, we're able to make those changes more quickly than in the past. We also use the registry with a psych consultant. We have an APRN who reviews cases and also meets with the care managers on a weekly basis to discuss patients' current status and what we need to do. She can also make recommendations to providers because at the heart of all of this, the primary care provider drives the care for our patients. And so, as you can tell, we're in the registry multiple times a day. If we're not using it with a psych consultant, we're using it in clinical supervision. It allows me to sort and look at acuity, and so our clinical supervision is more focused on the patient's needs than necessarily the therapist's needs or the therapist's concern. And so with all my therapists, I'm able to sit down and we're able to look at who are the patients who are the most acute and who has not progressed over time. And then it's also a tool that we use to drive our multidisciplinary rounds. These are meetings where we sit and meet with physicians, pharmacy, psych APRN, nursing staff to discuss patients. And we are using that time to look at our most acute patients to discuss what treatment changes need to occur. Do we need to look at a change in medication? Do we need to look at a change in therapy, or maybe adding therapy if they're only participating in care management services? So just a quick rundown. Those are a lot of the positives, but I do want to point out some constructive feedback that we have experienced with implementing a registry. First and foremost, I think that's a philosophy change, especially for therapists. I think the medical side is more familiar with using a registry, so it took my therapists a while to wrap their brain around that extra computer time. It does definitely require double documentation. We would love if there was an ability to connect it to our EHR so we weren't double entering those notes. It also is limiting in the sense that it will only track depression and anxiety for us. And so oftentimes we're running into situations where we would like to be able to monitor more diagnoses like bipolar. And honestly, the behavioral health department is the group of folks in our clinic who access it the most, and we are pushing the info to the medical providers. Although it is web-based, you can access it from anywhere. It is primarily used by therapists and care managers. And so that wraps up my experience with the registry. I'm more than willing to take any questions that people might have.
Thank you so much. It's very helpful.
Thank you, Anne.
Okay. I'm not seeing chat coming in, so I'm going to move along. Okay, so I'm going to talk a little bit about health information exchanges, and I'm assuming that most of you are familiar with what these are. Basically, it allows you to pool electronic health records across agencies, and that they are, of course, HIPAA compliant and secure and all of that. So we looked very carefully at the possibility of a health information exchange. We saw it sort of as a gold standard for data sharing, sort of like the randomized controlled trial is the gold standard for evaluation, attractive but not always possible. So we looked at some pros and cons of this. We contracted an HIE to engage in a subgrantee readiness assessment, and actually upon the results of that, we pulled the plug for the evaluation phase and are now considering it as one of several options for the scaling phase. Some positives of health information exchanges. There is the high potential for long-term gains, not only in information but also actually financially. I'm going to get into that a little bit. It can reduce redundant care, where providers can share test results, diagnoses, especially if a patient is bouncing from one provider to another. That's very helpful. There are a number of cons, though. The lead time is huge. I would say it's probably a good year to connect clinics to an HIE, and that's pretty much assuming that they have an EMR already. We also learned that many HIEs are low-capacity organizations, and one of the things we're going to do in our sort of gap year between the readiness assessment and deciding whether to move on with this as a permanent solution is to do some non-federal grant-making work and capacity-building work with the HIE in our C-Texas service area to help them be ready to work with our subgrantees. We also, some of the other issues around HIEs, they may not be 100% allocable to the project in terms of federal funding, because it's going to take care of providers and patients other than just those that are being served by the SIF project. So there are a lot of things to consider when making that decision. They can be politically charged, depending on who's sponsoring them and whether that agency has strong referral relationships with your subgrantees. There are just a lot of things to consider. So that was our experience diving into HIEs. I won't spend too much time on this because I know our time is limited. I want to move on to some other types of solutions, but would be happy to take any chat questions as we go. So moving on to constituent relationship management databases. The best known one is Salesforce, and I think at least, I saw one or two of you at least were using CRMs. There are a lot of really nice features to this, allowing multiple teams to access it from any location, which is great for multiple agencies working toward a common agenda. A lot of them come with very nice visual analytics, even mapping, and it actually can be a long-term solution for your subgrantees. But on the other hand, they're not specifically designed usually for health and human service programs and may need some customization, which tends to bump the price up. But it is a good one to consider. If anybody wants to make comments about by chat about their experience with the CRMs, I'm sure everyone would be interested to see that. Here's an example of visual analytics that come with a CRM type database. So you can see it can these things are built in, so it can save you a lot of time and effort on data visualization and reporting. Okay, so finally, last one on the list, our fallback solution, which is basically combining data in an Access database. This is very pragmatic. It's not the sexy choice. The downside is that it's short-term and it has no public-facing element. Data visualization is not really built in, requires time on the part of the evaluators or whomever is managing the database to produce visuals and reports. On the upside, it does get the job done on a very tight evaluation timeline, and full disclosure, that's what we're doing for our evaluation. So having looked at the long-term pie in the sky, we are currently just running very fast with our evaluation and using that solution. So that's the list. And then that brings me to a question that I had as I was looking at all these possible solutions. I would love to have you fill out this next instant poll. I'm curious, how important is it to you that subgrantees be able to share data publicly through some kind of online dashboard? And of course, that's with SIF approval on the sharing the evaluation results. So just on a scale from 1 to 5, how important is that to you to have that public-facing option? Okay, thank you. It looks like this is a fairly important feature for you, so definitely that's something that you should take into consideration when you're looking at subgrantee solutions for data sharing. And it's definitely nice if there's some attractive data visualization or drill down for that public-facing option. Thank you. Okay, so moving on, I wanted to talk a little bit about implications of your data sharing solution for grantee or subgrantee sustainability and scaling. One piece of that is who gets credit, especially in a collective impact project where everyone has a different piece of the puzzle. Teamwork is great, but subgrantees still need to show their own contributions to the effort, and this will help them attract match funding and other grants. So match funding being particularly important with the SIF model. Okay, so we want them to be able to attract new funding streams, and here are some different places that they might be able to attract funds with the right data solution. For example, if a nonprofit clinic can show that its patients had substantially fewer hospital readmissions or ER visits than other indigent patients, this goes directly to the bottom line of the hospitals in question. There's a very high return on investment for hospitals to fund local FQHCs and other community clinics because of this cost savings. So being able to demonstrate that is very helpful. An HIE is probably the most likely solution to make that possible because the other solutions are probably going to be limited to participants in the evaluation or grant project, whereas the HIE allows them to show impact across the whole healthcare community. And then finally, just building subgrantee capacity to gather and report data increases the likelihood that they can make the case for the value of their program to multiple funders, and that will benefit them after our dollars and the Social Innovation Fund dollars are gone. So I'm running a little short on time, so I'm going to skip that slide and go to the next instant poll. So have you seen evidence that data collection and data sharing has led to subgrantee sustainability? So basically yes or no, and then if yes, what sectors were providing those funds? So I'm very curious to see if you've had experience already with subgrantees being able to use data solutions to attract funds. And if not, maybe just think in terms of, if it's too early in your project, you might also want to think in terms of non-SIF grantees that you have. Okay, so fair amount of consensus that data collection and data sharing can lead to sustainability, and especially with other foundations. Not always clear on you know, the source of those funds, but it looks like in principle that is something that is happening out there, which is great. Okay, so now I have to give kind of a fair warning on sustainability. Here we are. Yeah, so the downside for sustainability is that some data sharing platforms do have substantial operating costs, and I am especially thinking of HIEs here. Despite their many advantages, they can be, depending on the solution, really expensive. There were a couple that our subgrantees were looking at that where it would add maybe $50,000, $75,000 a year to their operating budget, and they would be carrying that after the grant ended. So that's something you definitely want to consider, and be very careful in making sure your subgrantees understand that if that's a solution that they want to pursue. Okay. And then on the topic of scaling, we think this is very important, that data sharing is very important for scaling, because data sharing does promote collaboration, especially during the scaling phase, when you may be exploding out to more subgrantees or in more sites. And of course, it does allow multiple subgrantees to work as a team, which is nice. So I just have a few minutes more, so I just wanted to go through quickly some tips and lessons learned on data sharing from what we've done so far. And the biggest lesson is plan ahead. it absolutely will take you longer than you think to implement most of these solutions, and it could impact your evaluation timeline. So my advice, use a short-term solution for evaluation and then consider the longer-term solutions for the scaling phase. It sounds like some of the choices like the CRM and the patient registry actually could double for both of those things because they are relatively quick to get up and running. Second big lesson is get grantee buy-in well before you're ready to even choose a solution. So there are so many pieces to choosing a solution like this that funders may not consider, so be sure you have a lot of conversations with your subgrantees, give them opportunity to air their concerns, and don't require a particular solution if it is going to cost them money. That's just, you've got to be really careful about making sure that they have bought in. And then finally, right size for your project. So consider things like the public-facing option, long-term sustainability of the system, what type of project it is. And then finally, I'm going to get into a little bit more depth in my last couple of minutes on this. How sophisticated are your subgrantees in terms of managing data? I would highly recommend that you invest in a readiness assessment of some type, or at least a tool such as the HIMSS. If you're not familiar with HIMSS Analytics, that's a nonprofit that assesses the technological sophistication of healthcare agencies. So they look at how well are healthcare organizations capturing and using data. We use the HIMSS MRAM score, which has to do with EMR readiness as part of our HIE readiness assessment. They use an 8-stage model. You can see that represented on the left that tracks progress towards achieving a paperless patient record environment. And this can not only help to plan and execute EMR strategies, but also define a path toward meaningful use compliance, which is a big concern for FQHCs especially these days. Also available on the, you see on the right with the triangle, is the HIMSS Delta, and that measures data sophistication on 5 dimensions: data, enterprise approach, leadership, strategic targets, and analytical capabilities. And that's not terribly expensive. So I would recommend that you use one or more different types of assessments before you settle on a solution. So that wraps it up, basically. So any questions you have, I'd be glad to take those, unmute or chat in. And thanks so much for your attention.
Thank you, Ann.
Thank you.
Thank you, Ann.
Thank you.
Thanks, everybody.